All right. We're getting started with the live stream. So again, help me welcome Julianne here joining us. Julianne is a research instructor at the Department of Emergency Management at UNC, seat at Chapel Hill. She's also doing her PhD at Johns Hopkins University on aiming to get a Doctor of Public Health degree in implementation science. As I've heard, there's a lot of overlap between the work that we do at Gemini, so I'm really excited to have you here today, showing a bit of your work to us on opioids. The floor is yours. Thank you, Julianne.
Right, wonderful. Good morning, everyone. As I was just introduced, my name is Julianne Sear. My pronouns are she, her, hers, and I'm here to talk to you about, present to you on, and get some feedback on a project that I am in the early stages of development and launching. This project is called the Assessment of Opioid Use Prevention, Treatment, and Harm Reduction Strategies by Emergency Medical Services, or what we often know as our pre-hospital environment. Before we really get into the meat of the project, I'll tell you a little bit more about myself. So yes, I am a research instructor and the director of student research inside of UNC's or University of North Carolina, Chapel Hill's Department of Emergency Medicine. That means I design and implement a wide variety of projects, largely focusing on researching EMS, that pre-hospital environment, on researching implementation science concepts. So how do we utilize, adapt, promote a program in a new community, and researching medical education. In addition, as the Director of Student Research, I interface with a wide variety of students looking for research opportunities inside of emergency medicine, everyone from high school to undergraduate to medical school and residency. My educational history is I got a Bachelor of Arts in Psychology and Religious Studies. I know seems like an odd combination, and a minor in biology from North Carolina Wesleyan on the eastern side of our state. I got my MPH or Master of Public Health in Health Education, Health Behavior, and Epidemiology from St. Louis University, so I moved to the Midwest. And I am currently a DRPH candidate or Doctor of Public Health candidate in Implementation Science at Johns Hopkins. In all of that extra free time that I definitely clearly have, I also enjoy baking, hosting tea parties, cross-stitching, and hiking. To give you a little bit of background on why this project is so important, in 2023, we saw more than 17,000 emergency department visits and more than 4,000 deaths due to opioid overdose in North Carolina. Approximately 39% of decedents, or people who died, had EMS contact in the year prior to their death. So we know that there's an association between if you've died of an opioid overdose, you may have just seen EMS in the year before. We also know that despite evidence-based opioid use disorder treatments, stigma persists for patients, amongst clinicians, just in general for people who have experience using opioids. And that often prevents people from seeking treatment, from accessing care. We know that EMS systems play a key role in early intervention, but the current strategies and experiences of our clinicians, of our EMS agencies, are largely unknown. We don't have a database that tells us exactly what all of our EMS agencies are doing. There's only one statewide EMS protocol that addresses harm reduction, and that's the syringe exchange. And we know that these local programs exist, right? We can find a few of them online, but the effectiveness, the reach, the implementation are unstudied. We don't know what that's like, what that experience is, what the reach is, how those programs are operating. So the research objective today is to identify the use of and barriers and facilitators to pre-hospital opioid use disorder treatment, prevention, and harm reduction strategies, or those strategies that we can use in the ambulance kind of environment to help treat people, to help prevent them from ever starting to overuse opioids, and to help reduce some of that harm that comes with opioid use. The study overview. So this study is an explanatory sequential design using three phases. Now, when I say an explanatory sequential design, that means that I'll be using qualitative data at the very end to help really explain what we found from the quantitative data. In this pilot study, the three phases consist of two quantitative sides. The first is a statewide North Carolina EMS survey, which I'll explain in detail in a little bit. The second phase is really going in depth with one individual EMS system to say, what's your experience in delivering care to this population? What does your patient data look like? And then the third phase really incorporates stakeholder perspectives, those individuals who have lived experience, who interface with individuals who use opioids, community organizations that provide services. Now, the next few slides will go over some of those individual phases, the methods, exactly what am I proposing. The first phase, we describe opioid use disorder strategies. The aim here is to really identify opioid use disorder strategies currently and recently in use by EMS in North Carolina, really setting the stage for what on earth is going on in our state, what kind of services are we providing. The data collection method here, I'm proposing a survey. And for this survey, there would be an initial phone call to all of our EMS systems to really inform them about the existence of the survey, the fact that it will be coming to them shortly in email, making sure we have the right email address for them. The survey method being online provides that time for them to sit down with the survey, find the time that they actually need to just complete that piece. Following the initial phone call is that email that provides them the link, the instructions on how to use it, all of the consent information. The third contact is a follow-up phone call email at 2 weeks after non-response. So if we don't hear back from some of our participants, we will call them back just to remind them about the survey and encourage them to take it. The data analysis consists largely of descriptive statistics of all of the elements that we'll be collecting, and I'll go over a few of those as an example in the next slides. What we hope to gain from this is data on the use, the reach, and the beliefs about strategies, and we'll be comparing those by rurality and region. We really want to know what the stage is like across North Carolina, but also are there any differences by rurality, urbanicity, the three different regions across North Carolina. And we also hope to identify some of those gaps in prevention, treatment, and harm reduction programs. So based on the literature, based on what we know, what are EMS actively providing in terms of services, and where are some of those gaps where maybe this is an opportunity we could seek in the future? For this phase one, for this survey, I hope to collect data from all 100 North Carolina EMS systems. That's always the goal, right, is 100% participation. This survey is guided by an existing framework that was developed by Dr. Melody Glenn and a few other EM and EMS clinicians, administrators, researchers, and even a few folks of ours in North Carolina. This particular framework really walks through the prevention, harm reduction, and treatment strategies that they recommend are in use in North Carolina, and does talk about some of those second drivers, those change ideas, the reasoning as to why. This extensive framework can be found online if you do need a link to it. I'm happy to provide more information later as well. But I did want to inform you that this survey is guided by an existing framework. Now, this survey has been developed. We've received feedback from local EMS clinicians, administrators, and we've revised the survey based on that valuable feedback. The survey itself is estimated to take about 20 minutes, and there's approximately 25 questions. Those questions address the respondent and the EMS system demographics, so who's taking the survey and which EMS system are you representing? The different types of treatment, harm reduction, and prevention strategies that they're currently using, may have recently used in the past, or never used, and some open-ended questions to provide further information, feedback on the items that we've asked, or just things they want to tell us. I'm going to give you an example of a few of the questions that we've incorporated. And again, this is based off of that Glenn et al. Framework that you can find online. But in this first question here, we see which opioid use disorder treatment strategies has your agency used? And we can go through a very long list of all of the different strategies, complete with some definitions, some scroll over definitions for folks who don't necessarily know what MOUD, OTP, OBOT acronyms stand for. And then they get to choose the response that best fits whether or not they've used that strategy. As another example question, this one states, out of all of the possible pre-hospital harm reduction strategies, which three strategies do you think are most effective? for your EMS agency. And they get to choose up to 3 of the strategies that we've identified to really say, these are the ones that I think are most effective. At the very end, what you don't see is the options for other or none of the above as well. And then to give you an example of some of those open-ended questions, we have 2 on the screen here. We ask for any currently used opioid use disorder services. What advice do you have for other EMS agencies? Really to understand if something is effective, that they view as effective, how can we promote that in other EMS systems? What can we do right? And then the last question there is for any opioid use disorder related services that were discontinued, please briefly describe any lessons learned or insights gained. Again, really tackling how can we improve EMS, pre-hospital opioid use disorder treatment, etc. The status for this phase, I've submitted a UNC Chapel Hill IRB, which has been reviewed and exempted, so we are good to go on that end. We've gathered the contact information for a variety of EMS systems across North Carolina, almost all of them, not quite. And that data was gathered just through publicly available data of some of the best contacts in EMS systems, whether they're the medical directors, chief supervisor, etc. The project staff for this, besides myself, include a UNC undergraduate student who's been working with me to submit the IRB to make sure the survey looks good, works well, and then hopefully a potential medical student during the summer. UNC Chapel Hill does have a few funded opportunities for medical students to apply to, and so fingers crossed I also get a med student who will help out during the summer as well. Next, we're going to go on to phase 2. So again, this is a 3-phase study. The first phase was that survey of all of the North Carolina EMS systems and what they do for patients. And the second one really addresses missed opportunities. The aim here is to determine which pre-hospital opioid use disorder strategies were offered to opioid overdose decedents in the year prior to their death. So we want to know, before someone does die, unfortunately, of opioid overdoses, did they see EMS? Did they receive any services where they offered services? For this particular study, I propose a data linkage of 2024 decedent records with EMS records. And what that looks like is taking the North Carolina State Center for Health Statistics decedent data, so for example, from January to December 2024, and EMS patient records from the date preceding the year of death, and matching those 2 records based on fuzzy name and date of death match. So for example, if someone passed away from opioid overdose related causes on January 1st of 2024, I'd be looking at all of the EMS records starting on January 1st, 2023 and going up to their date of death. The data analysis itself is a lot of descriptive statistics, identifying the application of offering of acceptance of opioid use disorder interventions. This methodology is based on an existing paper entitled Opportunities for Emergency Medical Services Intervention to Prevent Opioid Overdose Mortality, which you can find on PubMed and accompanying search engines. What we hope to gain from this particular phase of the project is really learning about the association between patient demographic data and EMS offer and receipt of opioid use disorder strategies. We also want to know the frequency and nature of EMS interactions before death. So this study does take the previous study a step further to say, what exactly did we offer in terms of opioid use disorder strategies? Were they accepted? Not just really studying the did you see EMS and did you die in the next year. This particular study, we propose to use one specific EMS system, and we'll go into that in a little bit more detail soon, but an EMS system that is central to us, Orange County, very connected to UNC Chapel Hill. So again, UNC Chapel Hill has the Orange County EMS Medical Director as one of its EM faculty, which ends up being very convenient. Great guy, loves research. The Orange County EMS has signed a letter of support both from that EMS medical director who works in our department, as well as their PORT team, their post-overdose response team. Orange County is very lucky that it has a PORT team, has a wide variety of services that are available, and does really seek to reduce the impact of opioids locally. I'm also currently considering expanding to a rural EMS system, really to get a little bit of that diversity. Because this is an in-depth understanding of that EMS system's data, and how it relates to the next phase that you'll see soon, only working with a couple of EMS systems is very valuable. And that's because of phase 3. So phase 1 was that survey. Phase 2 is really looking in depth at the data in 1, maybe 2 EMS systems, linking them to decedent data across the state, identifying those missed opportunities. Phase 3 is the stakeholder perspectives. And in this one, we are identifying stakeholder perspectives and preferences for pre-hospital opioid use overdose intervention and collaboration. What does that mean, right? Well, it means I really want to work very closely with about 15 people in each of those counties, the 1 or 2 counties that I work with, to perform semi-structured interviews. Now, the types of stakeholders that might look like are the North Carolina Harm Reduction Coalition. Yeah, they're not based in just Orange County. They're, statewide, but they have an impact and influence across the state in providing harm reduction services. The UNC Psychiatric Emergency Services, the PES team out of UNC Chapel Hill. They, again, provide services locally to Orange County, and so have valuable insight into the experience, especially on the clinician side, of providing services. The Orange County EMS, a clear stakeholder, the people who, we're really trying to impact that system. We want their input. And probably most importantly of all is people with lived experience who reside in, work in, play in Orange County. Those individuals who have potentially received those services or avoided receiving those services for one reason or another. We absolutely want to hear those voices. The data analysis for these semi-structured interviews and all of the qualitative data that we would get from that is thematic analysis to really identify the strategy preferences, potential collaborations, and barriers to delivering pre-hospital opioid use disorder services. The products we want here are those initial impressions from our stakeholders and proof of concept that in the future we can bring together collaborators. We have people who are interested in talking about potentially expanding this area. And again, building that community connection. The phase 3 project status, we've had several letters of support from some of those potential partners that I showed on the previous screen, and I have sought a UNC academic investment fund but was not awarded for this entire project, so all 3 phases of this. I did meet with our academic investment fund liaison to discuss strengthening the proposal and do hope to submit that early this upcoming year. Now, what on earth would all of this work lead up to? So you're surveying North Carolina EMS systems, seeing what they're doing. You're diving deep into the patient decedent records of 1, maybe 2 EMS systems. Great. You're talking to a few people, really understanding their perspectives, their preferences. But what does that lead to? Well, what I hope this leads to is a community-based participatory research project where we co-design effective opioid use disorder interventions for those communities. So for example, if we're working with Orange County, we're working with the stakeholders that, play in Orange County, but maybe also across the state, like the North Carolina Harm Reduction Services. I want all of them to be involved in co-deciding how we can make the pre-hospital environment better for our patients. How can we deliver strategies that help treat, prevent, reduce the harm from opioid use? Now, the methodology behind that would look like intervention mapping. Intervention mapping is a multi-phase strategy that we use to design interventions. So we're starting from scratch with our stakeholders to build that from the ground up. Now, the partners are going to be a lot of the same people that you saw on that last screen. Most importantly, are people with lived experience, our EMS systems who we're trying to really impact, right? We want them to deliver the services. And then all those local hospitals, maybe some statewide partners, some harm reduction, prevention organizations that play in that area, that provide those services in that area. What I would bring to this future work is those data that I would collect from this pilot study, right? Those statewide survey data stating that this is what EMS across the board are currently doing or recently did, and a little bit of that effectiveness data. How many people did they reach? What kind of strategies do they think are most important? We'd also have the data inside of the EMS system relating back to individuals who died from opioid overdose. Did they offer any EMS services? And then those thematic analysis results from some of those partners stating, maybe these are some collaborations we see. These are some effective strategies that we could kind of consider in the pre-hospital environment. So we bring all of that, and a lot of that data is really the basis of the first step of intervention mapping, the needs assessment step. This whole process would look like a series of meetings between myself and all of these partners throughout a year and a half maybe, to go through the remaining steps. And those remaining steps of intervention mapping are on the screen, but I'll read them off to you anyways. They're the creating matrices of change objectives. So what do you want to change? Selecting theory-based methods and strategies. So we know there are plenty of evidence-based strategies. We don't know a lot about their use inside of the pre-hospital environment, but what do we think might be some of those effective ones we could use in EMS? Designing the program, so really selecting what kind of strategies we want to use and how that would look for EMS and for our patients and our partners, what kind of resources we might need. Planning for the adoption and implementation of it, so really setting the stage, figuring out any protocols, for example, making sure that we have any resources we might want to hand to patients, and then developing an evaluation plan. So again, all of those initial data would go into that first step of this long process of working with our community to really say, how can we reduce the impact of opioids on our community? To give you some insight onto my experience in that realm, I'm actually in the data analysis phase of a project that uses sort of a similar strategy to that one that I just proposed. Now, for this particular project, it is looking at the adoption of the basic emergency care course that was developed by the World Health Organization for use across frontline healthcare workers in Kenya. So a little bit of brief background on that. Kenya and a lot of other countries don't really have ready access to emergency medicine education, which becomes a problem when you need to deliver emergency medicine care. So to understand that, how can we really deliver that education? We're taking an intervention that already exists, the BEC, the Basic Emergency Care Course, and we've worked with stakeholders to say, how do we adopt this? How do we make this work for physicians, nurses, EMS? And all that data from the stakeholder meeting that I held was collected using a method called implementation mapping. So not intervention mapping, but implementation mapping. And that is actually based on intervention mapping, but takes one step that you saw and kind of expands that out and says, how do we collect data on that? So there is some basis of ability to do that, some like little bit of insider information in how that happens. But for this particular project that we're talking about, I'd love to open the floor to feedback, and pending no comments, queries, questions, I actually have my own things to ask you.
Awesome. Thank you. Thank you, Julianne. Great presentation. Thank you for taking the time and showing this awesome project to us. I wonder, is this your PhD thesis, or is it part of it?
No, it is not. My thesis is actually on the evaluation of the implementation and effectiveness, shocking, I know a lot of implementation science, of a pediatric emergency care coordinator program in rural North Carolina EMS, right? A lot of overlapping ideas there of EMS, a little bit of education, a lot of implementation science.
I see. Yeah, definitely a lot of overlap with a lot of research that folks do here. I think this will would be great to hear you talk about it if you have a chance in the future, and you want to share some of it with the group here. Opening the floor to questions. Anyone online or in the room would like to share some feedback or ask questions? Well, I can start. Through your process, you were talking about the 3 phases. And on the first phase, you are really aiming to get this like complete coverage of EMS services throughout the state. Do you have any idea of, if you are not able to get the total coverage, how much is enough for you to get a general picture, or is there any sample size analysis on this type of survey that you want to do? Just general thoughts here on I'm curious to hear on your side.
Yeah, that's a great question. I haven't done any sample size analysis or power analysis. I would generally hope for at least 30% of a response rate. Getting respondents in EMS can be notoriously hard, as we see across a lot of medical specialties. There are just so many surveys, so many demands on their time, so much time devoted to writing notes, to operating a medical system, that getting folks to respond can be a problem. Now, when I've worked on a past study in EMS assessing the implementation of a novel fluid resuscitation device for sepsis, looks like a giant squirt gun, delivers fluid really fast. I was surveying an entire EMS system, all of the clinicians, administrators inside of it. And for that one, we did use a financial incentive of, I think, $30 to fill out the survey and an additional enter into like a randomized raffle to receive one of two $200 surveys or incentives. I would love for a financial incentive for this one to really increase that response rate, but because of funding, I haven't done that yet, although I'm still looking at potential funding avenues for it. So short answer is no, I haven't done any sample size survey analysis. I'd love 30% at least. I am building in the strategy of recontacting people just to hopefully try to bump it up.
I see. And in that sense as well, like on your third phase, you had a list of champions and stakeholders that you wanted to interview and get their perspectives. Um, in like a backwards order, do you think you could maybe like use those champions or those stakeholders that have a closer contact to kind of advocate for you and then getting a higher, coverage on those surveys, or at least with that group specifically? I'm not sure if they are represented for the whole state or not, but maybe that could be a good start.
Yeah, that would be an interesting exploration. Because there's not really a lot of information out there about how EMS operate inside of opioid use disorder services, it would be difficult to say if there are already these connections between EMS and any of these organizations without going ahead and asking and diving deep into what have your experiences been like. So I wouldn't necessarily see myself using those organizations to help boost responses, but a really good option that I've been toying around with is trying to get the North Carolina Office of EMS on board, as well as a really close contact on the North Carolina Emergency Medical Services for Children, which is kind of like a subdivision, a hired position inside the North Carolina Office of EMS, to reach out to help say, hey, this is something that we are really promoting at the state level because we want to know what services we're providing. We want to know the data behind this. So I think that would be a very good partner for potentially boosting responses.
Awesome. And on this work overall, are you at this, you mentioned that you have a potential medical student coming to help you in this project. At this moment, are you interested in partners? If folks are interested, could they reach out to you and be part of this? What is the process there?
Oh, I would absolutely take more partners on this. I think even on the screen, the last last point is other partners. Not just from the perspective of, are there people I'm not planning to reach out to, like in phase 3, for example, who you think would be valuable, but people who might want to be engaged in this research, who might want to help out with this process, who are really interested in helping to reduce the impact of opioids on patients.
Nice. So you further, if you want to do research together, email Julianne and get that started. And then opening to the room and folks online if other questions are coming up.
And one question. This is Max Seegers. I work in the pediatric emergency department, and I'm curious kind of whether or not these interventions are being done in North Carolina or Orange County. Kind of what is the broad spectrum of interventions that are being done within the US for opioid use disorder? I guess I think of EMS kind of responding emergently to an overdose and then typically passing the patient off to the EMD or to the ED. And so kind of curious, it's an opportunity for intervention that I've honestly never thought much of in this scenario. And so I would just look, I think you mentioned like needle syringe exchanges, but that seems to be the one that's being done in North Carolina. What are the spectrum of things being done elsewhere?
Yeah, isn't that a fantastic question? There are so many research opportunities around this topic. I would absolutely love to work with folks to gather the facing, maybe not necessarily public facing, protocols for EMS across the nation. So as a insider tidbit into how EMS operate inside of the US, every state is different. No state necessarily operates the same. So when it comes to North Carolina, our Office of EMS provides all of the protocols in coordination with the North Carolina College of Emergency Physicians to all of our EMS. So everyone uses essentially the same protocol, a few caveats that we can totally talk about if you want to, but a few caveats. Now, that's not true across every state. Other states, there might be regional EMS systems. So if you live in Minnesota, the Western region might have a series of protocols that they all use, but that's different from everyone else in the state. Or in some areas, it's left up to the individual EMS agencies to say, what are your protocols, right? So truly is syringe exchange as one particular harm reduction strategy used widely across EMS in the US? I don't know. It's a great question. We could absolutely do a literature review. We could absolutely collect protocols and look at that, but I can't tell you what exactly is widely accepted yet.
Okay, if folks, thank you for coming, Julianne. I believe that folks can reach out to you after the presentation as well with additional questions. I see that you posted your email in the chat. Thank you, or from our collaboration as well. And you're more than welcome to come and talk about your thesis or the projects that you are working.
Thank you so much.
Thank you. We're gonna move. Sorry. So let's thank Julianne, everyone, for the great presentation again. And we're gonna move now to our more bureaucratic part of the meeting where we check in on projects. You are more than welcome to stay, Julianne, if you want, but it's you're free to leave as well. It's gonna be checking on the daily status of the projects.